Hi class. So today we're moving into disorders of the upper GI system. We're going to look at conditions affecting the mouth, esophagus, stomach, and duodenum. And as we work through these disorders, I don't want you, again, to approach them as a list of diseases to memorize. Instead, we're thinking about what's going wrong physiologically and how that explains what we see in our patient. So for example, if stomach acid is repeatedly moving upward into the esophagus, what symptoms would you expect? If the protective lining of the stomach or duodenum is damaged, what complications could occur? Those connections are much more important than memorizing isolated facts. So we'll focus on several common conditions, including oral and esophageal disorders, GERD, hiatal hernia, gastritis, and peptic ulcer disease. And as you move through this material, keep asking yourself 3 questions. What is happening physiologically? What cues would I expect to see in the patient? And which findings would make me concerned that the patient is developing a complication? And the last question is pretty important. Many upper GI disorders are manageable, but complications such as bleeding, perforation, obstruction, or aspiration can quickly change our priorities. So before we get into the individual disorders, these objectives give you an idea of what I want you to be able to do with the information. First, you will need to be able to recognize normal versus abnormal GI assessment findings. Think back to health assessment where we learned about inspection, auscultation, percussion, and palpation. In adult health, we take that foundation one step further. So when you recognize an abnormal finding, I want you to think, what could this mean for my patient? Is this expected with their diagnosis, or could this indicate a complication? Second, we're going to use the clinical judgment model throughout this content. When you're presented with a patient, you'll need to recognize the important cues, determine which ones matter most, identify the likely problem, and decide what the nurse needs to do. So instead of asking yourself, what do I know about GERD? We want to move towards, what do I notice about this patient with GERD, and what should I do about it? We'll also compare and contrast these disorders like we did with lower GI, and many upper GI conditions have overlapping symptoms. So epigastric discomfort, nausea, difficulty swallowing, reflux, or changes in eating. But the underlying cause and management may be very different. So understanding the pathophysiology will help you distinguish between them rather than memorizing those separate lists. And finally, one of our biggest priorities is recognizing complications. You need to know when a patient's condition is no longer routine. Things like GI bleeding, perforation, obstruction, aspiration, or significant fluid loss can become urgent very quickly. This is our agenda for today. So we're going to do a quick overview of the upper GI system. We're going to talk about gastroesophageal reflux disease, also known as GERD. We're going to get into hiatal hernia and then finish with peptic ulcer disease. So before we get into the individual disorders, I want to briefly orient us back to the upper GI system and what these structures normally do. So for our purposes, we're going to focus primarily on the mouth, esophagus, stomach, and duodenum, or the first portion of the small intestine. So we know that digestion begins in the mouth, where food is mechanically broken down through chewing and mixed with saliva. And we know that saliva helps lubricate food for swallowing and also begins some of the digestive process. Once we swallow, food moves through the esophagus, and the esophagus isn't really responsible for digestion. Its primary job is really transport. So coordinated muscular contractions called peristalsis move food toward the stomach. And at the bottom of the esophagus is the lower esophageal sphincter, or LES. And this is going to become particularly important when we talk about GERD. Normally, the LES relaxes to allow food into the stomach and then closes to help prevent stomach acid contents from moving backward into the esophagus. And once food reaches the stomach, we start seeing much more chemical digestion. The stomach produces hydrochloric acid and digestive enzymes, including pepsin, which help break food down, particularly proteins. But here's something important. The stomach has to protect itself from its own acid, right? The gastric mucosal layer or barrier, including the mucus and bicarbonate, helps protect that stomach lining. So when that protective system becomes disrupted, we can start seeing problems such as gastritis and peptic ulcer disease. So from the stomach, partially digested food passes through the pyloric sphincter into the duodenum, and here the acid gastric contents are mixed with bicarbonate, and digestive secretions from the pancreas and bile from the biliary system allow digestion to continue. So as we move through these disorders, think about where the normal process is breaking down. Is there a problem with swallowing or movement? Is acid going somewhere it shouldn't? Is the mucosal lining being damaged? Or is there a problem with gastric emptying? So understanding that normal function will make the pathophysiology of these disorders much easier to understand. So let's start with GERD, or gastroesophageal reflux disease. This occurs when stomach contents repeatedly move backward into the esophagus. And the key thing to remember is that the stomach is designed to tolerate acid. Remember, the esophagus is not. And normally the lower esophageal sphincter, or the LES, relaxes when we swallow to allow food to enter the stomach, and then it closes again. And with GERD, the LES may be weak or relax at inappropriate times, and this is going to allow gastric contents, including acid and pepsin, to reflux upward. So over time, that repeated exposure irritates the esophageal mucosa and can cause esophagitis. And so when you think about GERD, make that connection with the poor LES function to reflux and irritation and inflammation, where symptoms and potential complications could occur. So there's several things that can contribute to GERD. A hiatal hernia can interfere with normal LES function, obesity and pregnancy, increased intra-abdominal pressure, so potentially from obesity or pregnancy, which essentially pushes gastric contents upward. Smoking can also decrease LES tone, and that includes all smoking. So whether that be cigarettes or marijuana, certain foods and beverages can also worsen symptoms. Common triggers include fatty foods, chocolate, which is acidic, caffeine, also acidic, peppermint, alcohol, spicy, or just acidic foods in general. So I think about like citrus foods, spicy foods, like we just said, but remember that triggers can vary considerably from patient to patient, so that's going to be very individualized. And timing matters as well. Someone who eats a large meal and then immediately lies down loses that assistance of gravity in keeping gastric contents in the stomach. And that's why patients often report worse symptoms after meals or when lying down at night. The classic symptom is heartburn, which patients typically describe as a burning sensation behind the sternum. The other classic symptom is regurgitation, that sour or bitter tasting gastric content coming back into the mouth. But GERD doesn't always present as just heartburn. Patients can have chronic cough, hoarseness, sore throat, globus sensation, or even asthma-like respiratory symptoms, particularly when reflux occurs at night. One important clinical judgment point is chest pain. GERD can produce substernal discomfort that patients may describe similarly to cardiac pain. And we never want to assume that new chest pain is just reflux. So depending on the patient's presentation and risk factors, cardiac causes need to be considered and ruled out appropriately. So I also want you to notice the alarm symptoms on this slide, which is dysphagia, painful swallowing, unintentional weight loss, GI bleeding, anemia, and persistent vomiting. These are not symptoms we simply attribute to uncomplicated GERD. These findings warrant further evaluation because they may indicate a complication or another underlying disorder. And then for diagnosis, many patients with typical symptoms are initially evaluated based on their history and response to treatment. But when symptoms are persistent, atypical, or accompanied by alarm findings, we may need additional testing. An upper endoscopy, or EGD, this allows us to actually visualize the esophagus. We're looking for inflammation, ulcerations, strictures, and then changes associated with Barrett's esophagus, which is a precancerous change in the mucosal lining of the esophagus. If the diagnosis isn't clear, ambulatory pH monitoring can help measure how frequently and for how long the esophagus is exposed to acid. This is particularly helpful because it provides objective evidence of reflux. Then we have esophageal manometry, evaluates motility and LES function. It's not primarily used to diagnose routine GERD, but it can help evaluate swelling or motility problems, and it's often used when other diagnoses are being considered or before certain procedures. A barium swallow, this gives us more information about the anatomy, and it can help identify abnormalities such as a hiatal hernia or a stricture, but it doesn't directly measure reflux the way pH monitoring does. So the big picture I want you to remember is that GERD is an ineffective LES barrier that can lead to reflux of gastric contents and then esophageal irritation that then, gives our patient their symptoms. And along the road, if that continues, they can develop precancerous or even cancerous manifestations. So now that we've talked about GERD, let's look at hiatal hernia because these two conditions are really closely related, but they're not the same thing. So a hiatal hernia is an anatomic problem. So part of the stomach moves upward through the esophageal hiatus, which is the normal opening in the diaphragm where the esophagus passes from the chest into the abdomen. So normally the stomach stays below the diaphragm, but with a hiatal hernia, part of that stomach ends up above the diaphragm in the thoracic cavity. So there's different types of hiatal hernias, but I mainly want you to understand the difference between sliding and paraesophageal hernias. So a sliding hiatal hernia is the most common, and with this type, the gastroesophageal junction and a portion of the stomach slide upward through the diaphragm. These are particularly associated with GERD because moving the gastroesophageal junction above the diaphragm can then interfere with the normal anti-reflux barrier and the LES function. So when you see a patient with a sliding hiatal hernia, we want to think that reflux is probably one of the major concerns for our patient. Then we have a paraesophageal hernia, and this is different. The gastroesophageal junction may remain closer to its normal position, but then a portion of the stomach herniates upward beside the esophagus. These are less common, but potentially more concerning because the herniated portion of the stomach can become trapped or compressed, and that can compromise blood flow to the stomach. So with a paraesophageal hernia, we're thinking less about reflux and more about potential obstruction, incarceration, or strangulation. Many patients with hiatal hernias actually have no symptoms at all. They may find out that they have one incidentally when they're having imaging or an endoscopy for another reason, maybe GERD. But when symptoms do occur, especially with a sliding hernia, they often look very similar to GERD. So heartburn, regurgitation, dysphagia, chest discomfort, chronic cough, or hoarseness. Some patients also describe early satiety or feeling very full after eating, also bloating, belching, or nausea. Let's look at the risk factors on this slide, and you'll notice a common theme: increased intra-abdominal pressure. So things like obesity, pregnancy, chronic coughing, constipation and straining, and heavy lifting, these all increase pressure within the abdomen. And over time, particularly as the tissues of the diaphragm weaken with aging, that pressure can contribute to the stomach moving through the hiatus. Now for diagnosis and upper endoscopy, this will allow us to visualize the esophagus and the stomach and assess for associated problems such as esophagitis. A barium swallow, this can be particularly useful because it allows us to actually see the anatomy and identify the portion of the stomach that has moved above the diaphragm. Manometry, this may also be useful when we need additional information about the esophageal motility and the LES function. We want to pay attention though to the warning signs at the bottom of the slide, and we'll talk about that more a little bit with our activities. So a patient with known hiatal hernia who suddenly develops severe chest pain or upper abdominal pain, persistent vomiting, inability or significant difficulty swallowing, or signs of GI bleeding, this needs further evaluation, because those findings could indicate that we're dealing with something more serious than uncomplicated reflux. So the distinction I want you to remember here is that GERD is primarily a reflux problem, and a hiatal hernia is an anatomical problem that can contribute to reflux. And then with the different types, sliding, this is much more common, much more associated with GERD. And then the paraesophageal is less common, but we have greater concern for mechanical complications such as the obstruction or strangulation. So that distinction is going to become important when we're deciding what we're most concerned about in our patient. All right, let's talk about peptic ulcer disease. So this is different from some of the conditions we just discussed because now we have an actual break in the mucosal lining of the stomach or the duodenum that extends into deeper tissue. So the easiest way to understand peptic ulcer disease is to think about a balance between damaging factors and protective factors. So on the damaging side, we have gastric acid and pepsin, maybe H. pylori or medications such as NSAIDs. And on the protective side, the stomach and duodenum normally have mucus, bicarbonate, adequate blood flow, prostaglandins, and epithelial repair mechanisms that are protecting that tissue. So an ulcer develops when that balance shifts. So either we have too much injury or we lose some of those protective mechanisms. And the two major causes I want you to know are Helicobacter pylori infection, H. pylori, and NSAID use. So H. pylori is a bacterium that can colonize the stomach and disrupt the protective mucosal barrier. And this results in inflammation, making the tissue more susceptible to injury from acid and pepsin. And then NSAIDs, we know, can cause ulcers through a different mechanism. Remember your pharmacology here. So NSAID inhibit the COX enzymes, which decrease prostaglandin production. And prostaglandins aren't just involved with pain and inflammation, they also help protect the gastric mucosa by supporting mucus and bicarbonate production and adequate mucosal blood flow. So when those prostaglandins decrease, we lose some of that protection. And that's why I want you to pay particular attention to NSAID use when we're taking history from our patients. Patients may not even think to tell you that they're taking NSAIDs because medications like ibuprofen, naproxen, they're available over the counter. And someone might say, I don't take any medications. And then you find out that they're taking ibuprofen several times a day for their arthritis. So smoking can also impair healing and increase reoccurrence. We also have alcohol that can irritate the gastric mucosa. Severe physiologic stress, such as major burns, trauma, sepsis, or critical illness, these can also contribute to ulcer formation. One clarification about stress and spicy food. So we used to hear that stress or spicy foods cause ulcers, but for most patients, they're not primarily the cause of peptic ulcer disease. They may aggravate symptoms, but we have those common things like H. pylori and NSAIDs that are much more important causes. Now let's compare gastric and duodenal ulcers because students commonly mix these up. Both can cause epigastric burning or discomfort, but the timing in relation to meals can give us clues. So with gastric ulcers, eating may make the pain worse because food stimulates gastric activity and acid secretion. So these patients may experience pain relatively soon after eating. Because eating hurts, some patients begin avoiding food, which can contribute to weight loss. And then with duodenal ulcer, pain classically occurs a few hours after eating or during the night when the stomach is empty, and eating or taking an antacid may temporarily relieve the discomfort because food can make them feel better. These patients don't necessarily avoid eating. So don't treat those patterns as absolute rules, though. They're helpful clues, not enough by themselves to diagnose the type of ulcer, because patients may also have nausea, bloating, belching, early satiety, or decreased appetite. And importantly, some patients may have very few symptoms, particularly older adults. So paying attention to what your patient is saying, corroborating that with other clinical manifestations, diagnostics, history, all of that. So now I want you to pay close attention to the complication symptoms, because this is where our nursing priorities are going to change. And we're going to talk about this a little bit more with the activities. But if an ulcer erodes into a blood vessel, the patient can then develop a GI bleed. And if the bleeding is occurring higher in the GI tract, what might we see? So we could see things like hematemesis, or vomiting blood. Depending on how long that blood has been exposed to gastric acid, it may be bright red or have that characteristic coffee ground appearance. We can also see melena, or black tarry stools, because the blood has been digested as it moves through the GI tract. And so thinking about the obvious bleeding, what would happen if the patient were losing a significant amount of blood? We might also see associated symptoms like tachycardia, hypotension, dizziness, weakness, pallor, decreasing hemoglobin and hematocrit, and eventually signs of hypovolemic shock. Another major complication is perforation. So if the ulcer erodes completely through the stomach or duodenal wall, GI contents can then spill into that peritoneal cavity, and that's going to be an emergency. So the classic finding here is sudden severe abdominal pain. The abdomen may become rigid or board-like because, again, that peritoneal irritation, and the patient may eventually develop signs of peritonitis and eventually sepsis, shock, death. So if I give you a patient with known peptic ulcer disease who suddenly says, "This is the worst abdominal pain I've ever had," that's a very different situation from someone reporting that their usual epigastric burning, right? So peptic ulcer disease can also cause gastric outlet obstruction, particularly when inflammation, edema, or scarring interferes with gastric emptying. And those patients may develop persistent vomiting, abdominal fullness or distension, early satiety, and difficulty keeping food down. For diagnosis, the most definitive test is generally upper endoscopy, or EGD. This is going to allow the provider to directly visualize the ulcer, determine its location and severity, assess for bleeding, and obtain a biopsy when necessary. We also need to determine whether H. pylori is present, because that changes treatment. So testing for this can include a urea breath test, stool antigen test, or biopsy obtained during that endoscopy. And if we're concerned about bleeding, we'll also look at the CBC, particularly the hemoglobin hematocrit. Stool testing may be done, maybe an occult blood for the stool. And one final distinction. Gastric ulcers sometimes require biopsy to rule out malignancy, because gastric cancer can appear ulcerative. So duodenal ulcers are very rarely malignant, but it can happen. So the big picture here, as we end talking about peptic ulcer disease, is that the damage is overwhelming the mucosal protection, and ulcer is developed. Then our biggest concerns become bleeding, perforation, and obstruction. So when you're presented with a patient with peptic ulcer disease, we're not just recognizing that they have epigastric pain. We're asking ourselves, why did this patient develop the ulcer in the first place? Are they taking NSAIDs? Could they have H. pylori? Are they showing any evidence of bleeding? And is there anything suggesting perforation or obstruction? I know that was quick. We're going to have some great activities to put more of the pieces together, but I hope you have a great day, and I will see you in class or for the next lecture.